I'm here to discuss some of the things that we had been doing over the last few years, and it comes out of some other work that we had done. I have no financial interests or arrangements with any of the companies that I've dealt with here, and we just want to talk about bioengineered skin graft in Dupuytren surgery instead of using autologous skin for an improved outcome and for post-op pain management. And I have to say, I come out of University of Miami for my fellowship. I studied under Burkhalter. Ronnie Mann had just been here and had gone out to Utah, and he's one of the people that had popularized the McCash. And Burkhalter taught me the McCash, and I have to say the patients just loved it, so I never changed. And so this is a little bit of the history of, why did we add this in? And bioengineered skin graft was developed to use in skin coverage of ulcers such as the diabetic foot, venous leg ulcers. It's been shown safe and effective in those situations in providing skin coverage. It reduces healing time and risk of infection. And so that was, the beginning of all of these. It can provide cell therapy. So those cells really are just a delivery system for growth factors, cytokines, natural antibiotics, matrix proteins, and proteoglycans. And it acts as a barrier, physical epithelial coverage, biological, microbial penetration, and fluid loss. And it benefits a dermal matrix because you get cell migration for tissue regeneration and substrate to quench the proteolytic enzymes. So there's a number of things that are very nice about using these bioengineered skins. And they are living. So it's a delivery of a young, active fibroblast and keratinocytes. It's demonstrated to show persistence of the cells in the wound up to about 6 weeks, and that's even with this slough of the initial sheet that you put on. So it produces a new matrix material, fibronectin, all the other proteoglycans, cytokines, and growth factors. And there's kind of an edge effect in terms of increasing cells and interacting with the wound microenvironment, and it stimulates a neovascularization. This is back to the hormones and the growth hormones. So we used it in an off-label use, and we actually presented this at ASSH back in the early 2000s, and we used it in the release and application on epidermolysis bullosa patients because we have actually a significant number of those coming into town or in town. And we looked at 5 out of 6 patients, and basically we just dissected their hands, so to get rid of the pseudomembrane and release whatever contractures they had, graft the areas, and use Mepitel dressing, although we actually have revised that. And so we had 100% take of the bioengineered skin graft. And EB is kind of a special situation where you actually can get this chimera phenomenon. But all the wounds were healed by 6 weeks. We didn't have to use their skin. All the patients were able to regain functional use, and there were no surgical complications. And so it's just one of these mitten hands, and then opening it, and you can see that there's, again, multiple McCashes, and then putting the skin over it. So we were very happy with the way that worked for us, and the patients really loved it because they were able to use their hands again. So we then thought, well, would Dupuytren's be a good situation for this, particularly in redo Dupuytren? So we started by doing fasciectomies. There's a lot of evidence to remove skin over the fasciectomy, reducing a recurrence rate. Myofibroblasts, you've all been through all of this matrix for cell migration, cytokines stimulating new skin growth. So after dermatofasciectomy, Dupuytren's recurrence is about 10%. Used for aggressive Dupuytren's of the diffuse type with well-defined cords, and controversial, but it's difficult to predict the recurrence. And then doing kind of a fire break technique in terms of resurfacing a fasciectomy, would that help? And of course, there's obviously evidence for that as well. So we decided to use that in our McCash incisions, and initially the McCash, it's an aggressive approach, but it's not as aggressive as a complete excision of skin. You're just releasing the skin and then excising the fascia underneath. And if recurrence or progression happens, you go back to a fasciectomy or dermatofasciectomy. So instead of using the autologous grafts, this is where we use the Apligraf, and that's the particular brand name, but it's just a bioengineered skin. And so instead of closing the skin with a skin graft. We just put the bioengineered skin over it. And so here's a cord. This is the transection of the cord, and then placing the engineered skin over it, sewn into place. And we just use 6-0 plain, and we use non-adherent dressings. So instead of using the Mepitel, which was originally developed for the EB kids, we actually shifted over to Adaptic with gentamicin ophthalmic drops, and then just put a second layer of gauze on that, and then the therapists only change the gauze on top of the Adaptic, but do not change the Adaptic, and we just reapply the drops. So the dressings removed in hand therapy, but the non-adhering dressing left in place, treated again with the ophthalmic drops, and then just begin moving them. The engineered skin graft dries out at about 7 to 10 days, so it acts really like a scab in this setting. If you don't use the antibiotic drops, it actually kind of sloughs off at about 4 to 5 days. And then once it does slough or dries out, we just continue with soap and water, just as if they were a routine McCash. And then this is just an example of wound healing progression. And it looks pretty wild, and people look at it and go, oh my gosh, but they don't have the pain. So people we had originally done McCashes on one side, we've turned around and done it with the Apligraf, and they've just said, oh my gosh, if I had known that you had this now, I would have come back sooner to get the opposite hand done. And and we just start them moving right away. They really don't have too much trouble with motion. And then these are the outcomes. And so our hypothesis was using the tissue-engineered skin graft reduced the incidence of recurring Dupuytren's contracture and improved the outcome. And we've been doing a retrospective review, but in the midst of that review, I left the university, so it's been a little bit difficult to get some of the patient charts. But these are patients that we had done since 1999 to 2007, and 11 of the 36 patients that we had for follow-up had the bioengineered skin graft, and the mean follow-up time was 6 years. So we sent DASH and request photos, and so the student t-test, two-tailed, was used to compare healing times with bioengineered skin against just a routine McCash left open. And the average follow-up time was 76 months. So our average DASH score for this group was 8, with no recurrences in this particular group. But we feel it's pretty small at this point, so we don't really want to draw too many conclusions with it. And the wounds covered with bioengineered skin healed at an average of about 40 days, but the uncovered ones healed at 27 days. And so that, the regular open McCash actually healed quicker. Statistically significant difference in healing time. So did the engineered skin actually kind of delay the healing? And if so, why? The scars healed well for all the patients. And so this is just an example of 2.5 years after surgery and then 5 years after surgery. And you can see there are some recurrences or progression. It's hard to say which sometimes. And this is another one. And comparing the two sides. So basically, for post-op management, it's a burn wound dressing. And the study on wound pain, the donor sites for split thickness graft covered with engineered tissue in one group and oil gauze in another group. The wound pain was reduced in the group with wounds covered with a bioengineered tissue. So we think that that's part of the reason why our patients actually did pretty well. In terms of pain, but we also looked at motion before the surgery and at the time of wound closure, and that's all we had available for the affected finger in 7 patients with the bioengineered skin. And the average percentage range of motion improvement in the PIP joint was about 29%, and average percentage improvement in range of motion in the MCP was 47%. And I will say that these early patients, for the most part, were really severe contractures or redo. And so the PIP joint range of motion, again, just an example. And through each of these patients that we had good follow-up for post-engineered graft, you can see that post-op, the PIP joint in the majority of patients improved dramatically, but in 2, it did not change much. And also in the MCP joint, for the most part, improved dramatically, but in 1 patient did not. And so our conclusions at this point, for us, this is like a focus group. This is what we were able to pull out of our original look, but we are going back to look at a more comparative, controlled setting, was that we did have a good outcome. We didn't have any donor site morbidity. Time to wound closure is longer, but the post-op pain is reduced. And what is that mechanism of action? We're not quite sure about that. And our prospective randomized control study, that's what we need to do in the future. And we need to look at the bioengineered skin versus a regular open McCash and do a range of motion measurements pre and post surgery and follow them for really close to 5 years. You just have to get something out in the distance, and I think everybody in this room already knows that. So that's basically it for us. And any questions?